Good morning, dear colleagues. My name is Mince Kilian, and I represent the departments of urology and radiology of the Danilo Halevsky National Medical University. And I want to say thank you to the organizers of this Congress and to the European School of Urology for the kind invitation. I'm very delighted to speak on this session. My clinical case is dedicated to the middle-aged patient with the lower urinary tract symptoms. This consultation took place in the previous year. The young patient with the lower urinary tract symptoms, such as episodes of dysuria, urethral burning, frequent urination, and the perineal discomfort. These symptoms were exacerbated by cold and also worsened after the ejaculations. Whitish prostatic discharge and persistent irritative symptoms despite the negative cultures were observed, and also history of prostatitis with multiple antibiotic treatment in the last 5 years. Also, in this patient, the PCA fluctuations were observed. In 2024, the PCA was 5.57 and percentage of PCA ratio was 10, and in 2024 the PCA was 4.95, and with even lower PCA ratio in a negative digital rectal examination. In this patient, also the features of the inflammation in the prostatic secretion were observed with no family history and no systemic comorbidities. And also, I would like to note upfront that all diagnostic procedures for this patient were performed in external clinics and institutions. A year ago, before the consultation, the patient underwent the MRI of the prostate due to the increased PCA level and mentioned before complaints. According to the radiologist's report, the PIRAS 2 lesion in the left peripheral zone was observed. The lesion was non-enhancing. In the gland volume, a little bit increased, and also BPH pattern PIRAS 2 was observed with no signs of the extraprostatic extension, with no suspicious lymph nodes or skeletal metastasis. And also, at the time, the patient concerned about the potential proceedings with biopsy due to the ongoing inflammation. Based on the data of this MRI, the results were reassessed, and the MRI data was reassessed in our academic center, and the lesion was reclassified as the PIRAS 4 based on its features and localization. This feature, according to our assessment, was localized in the anterior fibromuscular stroma and also in anterior segments of the transition zone and of the peripheral zone. It was hard to define the zone of origin. And based on this criteria, we used the criteria for the peripheral zone, and also the ADC parameter of the lesion was very low, 0.68. And in the result, the patient was recommended to undergo the targeted biopsy due to the high suspicion of clinically significant prostate cancer, but given the interval 12 months in the last MRI and the repeat MRI recommended before the biopsy. In March of 2024, the patient underwent a second MRI in external center abroad. The PCA at this time was 5.54 and PCA density 0.16. But according to the radiologist's finding, again, the PIRAS 2 lesion was observed in the transition zone, the mild BPH features with no suspicious lymph nodes, no hemorrhage, and also the signs of the inflammatory and post-inflammatory changes. Again, based on this MRI data, these data were independently reassessed in our center. And again, the lesion was observed in the anterior fibromuscular stroma and anterior segments of the peripheral and transition zone. The lesion increased in size, and the ADC value decreased compared to the previous MRI. So again, the lesion achieved PIRATS category 4. So, and in April of the 2024, following a consultation with another urologist and another expert external center, the patient underwent a transperineal truss-guided systemic biopsy, the 12 course, and in the result of histopathological examination, all cores were benign, in all cores were benign tissues with the chronic inflammatory infiltrates, with preserved architecture, with no neoplasia, no atypia, and no malignancy detected. In post-biopsy period, the patient developed acute exacerbation of symptoms, including lower urinary tract symptoms, such as severe pelvic pain, burning during the urination, frequent urination, and subfebrile temperature. But after the successful antibiotic and anti-inflammatory therapy, these symptoms disappeared, and the patient was recommended to undergo regular PCA monitoring, and in case if the PCA rises, to repeat the MRI. In March of this year, the rapid PCA up to 9 nanograms per milliliter was observed, followed by the slight decreasement, and the PCA ratio was 10% at the time. So the patient underwent again third MRI in the International Expert Center, and finally the PIRATS 4 lesion was observed in the same location as previously. Compared to the previous examination, the lesion increased in size and with no extraprostatic extension, no seminal vesicle invasion, no lymphadenectomy. And as we can see on this image, if this lesion if this lesion is assessed according to the transition zone criteria, this lesion should achieve PIRATS 3 category, but due to the very significantly restricted diffusion in decreased ADC value. But if this lesion would be assessed according to the criteria for the peripheral zone, definitely this lesion should receive the category PIRATS 4. So additionally, the three-dimensional DVI-based lesion reconstruction was exclusively performed by me for this patient in order to enhance the precision of the targeted biopsy. As we can see, this lesion located in the apex of the gland, which corresponds to with the initial plain MRI images. In June of this year, following the consultation with another urologist at the separate external urological center, the patient underwent transperineal fusion-guided biopsy under the truss and MRI overlay. It was systemic plus targeted biopsy with assessment of this lesion located anteriorly. According to the histological findings, the adenocarcinoma of the prostate, SNR type, and also foamy gland variant was observed. It was Gleason score 6, 3+3, ESU grade 1, and also chronic inflammatory infiltrates were seen. Cancer was present in 6 of 10 cores with maximal linear involvement up to 11 millimeters with no perineural invasion, no neuroendocrine differentiation. And according to the immunohistochemistry, the profile was consistent with the carcinoma phenotype. So case discussion. The foamy gland adenocarcinoma is a rare variant of the SNR prostate adenocarcinoma. It accounts approximately from 14 to 23% of all prostate cancer in radical prostatectomy specimens, and characterized by the abundant foamy cytoplasm due to the intracytoplasmic vesicles, minimal cytologic atypia, and pycnotic nuclei, and what is very important, often mimics benign glands, leading to the potential underdiagnosis. Also, it has the specific immunohistochemic profile aiding in differentiation from benign mimickers. The prognosis in case of this foamy subtype of the acinar adenocarcinoma is similar to the conventional acinar adenocarcinoma when matched for the Gleason score and stage with no particular predictive significance, and the Gleason score range from 6 to 10. However, in a majority of these types of the tumor, the Gleason 4 pattern is observed, and also cribriform growth pattern may be observed, and in majority of cases it is mixed with the conventional acinar type of the adenocarcinoma, with no difference between the foamy gland and non-foamy histology in recurrence rate, and no difference with time to prostate-specific antigen recurrence. On MRI images, these lesions can present as the PIRATS 4 or PIRATS 5 lesion due to the infiltrating nature, but there is no data on the difference on MRI presentation in literature. And the discordance in PIRATS assessment in this current case is likely due to the limitation in the current evaluation criteria. According to the latest PIRATS guidelines, since the prostate cancer is not originate in the FMES, lesion in this region could be assessed using criteria for either peripheral or transition zone, depending on the presumed origin. And however, in this, the zone of origin is not always clearly identifiable, as in this case, and this is a recognized limitation of the PIRATS assessment methodology. At the same time, according to the latest EU guidelines, adding the MRI targeted biopsy to the systemic biopsy in the primary setting could significantly increase the detection up to 13% of the clinically significantly cancers, and in repeat biopsy setting up to 15%. At the same time, omitting the systemic biopsy in the primary setting could lead to the missing of the up to 18% of this clinically significant cancers, and in secondary settings only up to 3.9% of the ESUP category 2 and only 1.6 ESUP category 3 cancers could be missed. So according to the guideline recommendations, when the MRI has shown a suspicious lesion, the MRI targeted biopsy can be obtained through the cognitive guidelines using ultrasound and MR fusion software or indirect inboard guidelines. And when the MRI is positive, for example, as in our case, PIRATS 4 lesion is observed, we should combine targeted biopsy with a perilesional sampling. Reporting discrepancy between the PIRATS 2 in external centers and PIRATS 4 in expert reassessments, in our case, complicated the choice between the targeted only and combined biopsy strategy. If we talk about the treatment consideration in the foamy gland variant of prostate cancer, the management is generally guided by the Gleason score, tumor grade, and patient factors, and is similar to the conventional prostate adenocarcinoma. Also, in our case, the patient has the lesion ESUP grade group 1, the volume of which exceeds the Epstein criteria of insignificant prostate cancer, the PIRATS 4 category, the markedly low apparent diffusion coefficient which is known predictor of ESUP grade in prostate cancer, and anterior localization of the lesion, and possible due to that biopsy sampling error due to the diagnostic limitation in such regions, and also foamy histology, which suggests a risk of pathological upgrading to clinically significantly prostate cancer after the prostatectomy. It supported the classification of this lesion as the clinically significant prostate cancer. So at current stage, the patient faces the decision regarding the definitive treatment of prostate cancer. So the conclusions. The presented case illustrates that in younger patients with a persistent lower urinary tract system, symptoms. The only symptom, careful MRI interpretation, biopsy strategy planning, and the clinical correlation are critical. The foamy gland variant is a rare but significant subtype of prostate adenocarcinoma that can mimic benign conditions histologically. MRI findings may not always correlate with histology, thus comprehensive evaluation is essential. Also, the PIRAT system provides structure assessment. Its interpretation remained very operator-dependent and inherently subjective, with significant inter-reader variability and its own limitations. Adhering to the recent EU guidelines is essential when selecting the optimal biopsy approach. Lesions located in the anterior segments, for example, anterior transition zone or anterior fibromaxillary stroma, remains a diagnostic challenge even with the transperineal MRI ultrasound fusion biopsy. In selected cases, repeat biopsy may be required due to the limited accessibility and sampling error. And finally, multidisciplinary approach involving urologist, radiologist, and pathologist is crucial. Thank you very much for the attention.